Tendinopathies. This course is approved for 6 hours of QME continuing education by the Division of Workers' Compensation. This is your author and narrator, Dr. Perry Carpenter. I hope you enjoy the program.
Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's video. In today's video, we're in session number 4 of our ongoing series entitled Permanent Impairments of the Tendinopathies. And today in session 4, we're beginning section 2, the second half, the second part of this series. And in the first part of this series, we spent great time talking about statistics of tendinopathies in the industrial setting. We spent quite a bit of time talking about the anatomy of the connective tissues and of tendons as a subset of the connective tissues specifically. And we spent great time in our last session talking about the differences in the anatomy and the physiology and the pathology between normal healthy tendon and abnormal pathologic degenerative tendinopathy tendon. And now, moving forward in this program, we want to talk about some of the clinical aspects of the tendinopathies, specifically focusing on tendinopathies of the shoulder, of the elbow, of the knee, and of the ankle, and talk about how it is that injured workers in the California workers' compensation system come to present with these types of problems. And when examinees present with tendinopathy problems at the permanent and stationary date, if they're left with residual sequela of tendon injury, how to provide for permanent impairment ratings for these conditions that will likely never return to pre-injury condition. So in today's discussion, we want to talk about risk factors associated with tendinopathy in the industrial setting. And I want to talk to you about various options that you may have available to you to provide for an accurate permanent impairment rating for these examinees using both the strict application of the AMA guides and then also by using an alternative impairment rating under Almarez and Guzman. So I have a fascinating series of discussions for you over our next 4 sessions. And so with no further ado, let's begin today's discussion, permanent impairments related to shoulder tendinopathies.
Okay, so let's begin with some facts and some statistics regarding shoulder tendon injuries in the industrial setting. And I want to share with you a couple of interesting facts from the journal Orthopedic Rheumatology, which is a 2015 review of shoulder tendon disorders in the occupational setting. So the review took place in 2015, so it may involve some what we consider to be some older statistics. In fact, the statistics relate to Bureau of Labor Statistics findings in 2012. But these are the latest statistics that we have, and probably in 2018 we'll have statistics from 2015, but these are the current statistics as we know them. So according to the Bureau of Labor Statistics, approximately 1,100,000 cases of what are known as musculoskeletal work disorders, the MSWDs, musculoskeletal work disorders, are reported. And of those 1,100,000 musculoskeletal work disorder cases, the median involves 9 days away from work, which is equivalent to 41,500 years of lost work days on an annual basis due to musculoskeletal work disorders. Well, of those 1,100,000 cases, shoulder injuries accounted for a 13.6% of the musculoskeletal disorder claims. So somewhere between 10 and 15% of all MSWDs involve the shoulder. And this probably does not come as a surprise to you that so many shoulder cases would be involved. And of the shoulder injuries, most of those shoulder injuries involve tendon disorders, tendon injuries of the rotator cuff and bicep tendons. So let's talk a little bit about the rotator cuff and the bicep tendons and what it is that predisposes them to such a high incidence of industrial injury. So rotator cuff tendons are dependent on their structure and cellular organization for function and response to physiologic loading. The physiologic loading is another phrase that we could substitute for the phrase work demands. It's the work demands that apply physiologic loading on these tendons. And anytime we have a disruption in either the structure or the cellular organization of these tendons, in other words, anytime we have a loss of homeostasis of these tendons, that's going to result in pain, that's going to result in tendon degeneration, and that's what's going to lead these examinees to us for a permanent impairment rating. So remember that tendons have a nonlinear viscoelastic response to applied cyclic tensile loads, and we should also say applied cyclic compressive loads, because tendons are subject to two types of loading: linear tensile loads and compressive loads. So the nonlinear viscoelastic response is that tendons undergo lengthening to an applied load. Well, the lengthening returns to baseline in a certain period of time in healthy tendon, but in unhealthy tendon there's a delayed return to physiologic tendon length. And if cyclic loading is applied before the tendon returns to baseline, that's what upsets the homeostasis of the tendon and sets the stage for the tendon degenerative continuum, which we talked about in our last discussion. Now, the precise loads necessary to induce degenerative processes depend upon age, depend upon sex, and depend upon the location of the body, or I should say depending upon the specific tendon that is involved. And we'll talk about age in just a couple minutes, but with regards to gender and location, it seems that males and females have predilections for tendinopathies at different rates depending upon the tendon that we're talking about. So for example, in males, there's a much higher incidence of Achilles tendinitis or tendinopathy, much higher incidence of patellar tendinopathy, and a much higher incidence of adductor, hip adductor tendinopathy than in women. Whereas in women, gluteus medius tendinopathy presents almost exclusively in women. The upper limb tendinopathies, such as medial and lateral epicondylitis, and rotator cuff tendinopathies are approximately equal among men and women, and the difference seems to be related to hormonal and metabolic differences that affect men and women's tendons differently, and therefore affect the incidence of injury to these specific tendons. With regard to aging, by the age of 70, the rate of asymptomatic rotator cuff tendinopathy can be as high as 60 to 70% of the population. And that's interesting because not all of these sufferers of tendinopathy have symptoms. So it's possible to have degenerative tendinopathy even in the absence of shoulder pain symptoms. Now, rotator cuff abnormalities in asymptomatic people is high enough for degeneration of rotator cuff to be considered a common aspect of normal human aging. And that might not come as too much of a surprise for you if you consider that we consider some of the other degenerative conditions of bone and of muscle to be common aspects of normal human aging, such as, for example, osteopenia or loss of normal bone mineral density of bone is considered a common aspect of normal human aging. Similarly, sarcopenia, which is the loss of muscle tissue, muscle mass, and muscle strength, and muscle force production capacity, that's also a normal aspect of human aging. So with tendon being sort of the link, the interposed link between muscle and bone, why would we consider it abnormal for tendons to undergo degenerative changes as a result of aging? And it's becoming a common philosophy now, and accepted philosophy, that tendinous degeneration is a normal aspect of human aging. In addition to normal degenerative aging of tendons, it seems that other aspects of the shoulder associated with aging contribute to the development of shoulder tendinopathy. So as one example, the shape of the acromion process of the scapula can greatly affect the potential for rotator cuff tendinopathy. And acromial shape appears to progress from a type 1 or flat acromion to a type 3 or hooked acromion, reaching as high as 93% of those over 70 years of age. So amazing. The shape of the acromion process seems to change throughout the aging process, thereby further contributing to external impingement of the rotator cuff and contributing to the development of rotator cuff tendinopathy. And I just want to read a couple of quotes here for you from the abstract of a recent study in the Journal of Shoulder and Elbow Surgery. This is a study entitled Changes in Acromial Morphology with Age. So let me just read a couple quotes from this study. They state that it has not been determined whether acromial morphology is an innate anatomic characteristic or whether it represents a degenerative process, with type 1 acromions changing to type 3 acromions over time. And so they go on to conclude that the incidence of the 3 acromial types varied between patients with and without symptoms of mechanical impingement. The incidence of the 3 acromial types varies with respect to the age of the patient and whether he or she has symptoms of mechanical impingement. This raises the possibility that type 1 acromions may progress to type 2 acromions and then further change into type 3 acromions over time. So as the shape of the acromion process changes over time, it increases the mechanical impingement over time on the rotator cuff tendon, thereby contributing to the development of rotator cuff tendinopathy. So let's take a look at some of these acromion shapes and how these acromion shapes affect the rotator cuff tendon. Okay, so here we have both an image and an x-ray of the shoulder complex depicting the acromion here, coracoid process here, head of humerus here, and the subacromial outlet indicated here under this space. Now, there's several factors to consider when you're assessing for the potential for rotator cuff tendinopathy. So as we mentioned in the previous slide, the shape of the acromion process tends to progress from a flat undersurfaced acromion process to a more hooked undersurface acromion process over time. And as the acromion becomes hooked on its undersurface, you can see what that does to compromise and impinge upon this delicate subacromial space. So imagine this. Imagine the combination of a hooked acromion process with its adjacent coracoacromial ligament here, forming the roof of the subacromial outlet here. That forms the roof of the subacromial outlet. Well, every time this arm becomes elevated greater than 45 degrees, this rotator cuff tendon here, this is the rotator cuff tendon, this here would be the supraspinatus tendon, and then this here, this would be the infraspinatus tendon here. This would be the tendon of the teres minor here. So every time this arm is elevated greater than 45 degrees, these tendon fibers here on this superior aspect of the head of the humerus become compressed underneath this arch formed by the acromion process and the coracoacromial ligament. So I want you to imagine these fibers here on the top of the head of the humerus sort of being graded and compressed and drawn back and forth across this subacromial arch, kind of like friction being generated on the surface of that tendon. So as we're going to see in industrial settings, these tendon fibers are going to be subject in this area to both tensile loads and compressive loads, with the compressive loads being produced by friction or mechanical impingement up against the subacromial arch, and the tensile loads being produced by the muscular contraction forces of the supraspinatus and the infraspinatus muscles as this arm is subjected to loading. Okay? And we'll talk more about that in just a minute. So here shows the osseous acromial outlet with a downward sloping hooked type 3 acromion process here, and you can see how that significantly compromises the subacromial outlet where the supraspinatus tendon exits in this area right here. So with aging, we see a progression of the acromion process from the type 1 flat to the type 3 curved acromion process. And that brings up the concept of what's referred to as the occupation ratio. So this diagram right here is depicting a type 1 acromion process with the undersurface of the acromion process being flat. And the blue circle is depicting the supraspinatus tendon. Well, with a type 1 flat supraspinatus tendon, there's a relatively larger available space in the subacromial space to allow passage of the rotator cuff tendons and the subacromial bursa. Whereas with type 2 and certainly with the type 3 acromion process, the available space, the available subacromial space is greatly reduced, thereby predisposing these types of individuals to mechanical impingement and the development of rotator cuff tendinopathy due to a smaller area available for the tendons and the bursa. So these are some external risk factors for the development of rotator cuff tendinopathy based on changes in shape of the acromion process as a result of the normal aging process. Now, in addition to mechanical impingement by the acromion process, as we're going to see in diseased tendons, tendinopathy tendons, degenerative tendons, the size of the tendon is going to increase. So imagine that this blue circle here increasing in size and circumference by 20%. You can see that any increase in size of the structures in the subacromial space is quickly going to fill up the space and increase the occupation ratio, the ratio between the amount of available space in the subacromial space compared to the amount of substance within that space. So with thickening of the tendon, imagine what would happen to this particular tendon here and this particular tendon here if those two tendons were increased in size and circumference by, say, even as little as 25%. It wouldn't be very long before there is mechanical filling and mechanical impingement of that tendon. So when either of these phenomenon, such as changing in shape of the acromion process and or thickening of the rotator cuff tendons, when either of those two processes take place, it accelerates the development of degenerative tendinopathy. Unfortunately, once the degenerative tendinopathy develops, the thickening of the tendon becomes largely irreversible, and this is what's responsible for the continued pain and the continued degenerative process of these rotator cuff tendons, because it becomes nearly impossible to get the tendon to recover to its normal pre-tendinopathy size and circumference. And this phenomenon was recently described in a 2017 study published in the British Medical Journal of Open Sport and Exercise Medicine. And in this study, what they did was a fascinating experiment. And I'll talk about the method in a minute. But what they found is that the supraspinatus tendon in painful shoulders compared to non-painful shoulders, this tendon significantly increased in thickness in response to acute fatigue loading compared with pain-free shoulders. And if you remember to session 2 in this program, we talked about the changes that can take place in the extracellular matrix of tendons as a result of degenerative tendinopathy. In degenerative tendinopathy, what we see in the extracellular matrix is that the extracellular matrix becomes more aqueous, it becomes more fluidy, it becomes more puffy, it becomes more edematous, it also becomes more vascular and subject to hyperemia. So these factors contribute to swelling and an increase in thickness of abnormal tendon compared to normal tendon. So in this study, they took people with pain in their shoulders, and they had a control population of people with absent pain in the shoulders, and they subjected both groups of people to a loading protocol. So let me describe the loading protocol. The loading protocol involved putting the subjects in a seated position using an isokinetic dynamometer, and the dynamometer was able to apply a consistent load to the subject in both concentric and eccentric phases of contraction. Okay, and so the isokinetic dynamometer is able to register the force exerted by the subject, and when the subject becomes unable to consistently exert force against the dynamometer, they interpreted that as the onset of fatigue. So participants undertook a 5-minute shoulder warm-up involving range of motion exercises. The loading protocol involved 2 bouts of exercise, one of concentric and eccentric shoulder abduction, and a second of concentric and eccentric shoulder external rotation. And the order of these 2 sequences was randomized by coin toss. And what they found was that loading the rotator cuff to fatigue also resulted in a reduced subacromial space, with recovery to baseline delayed up to 24 hours in people with painful rotator cuff tendinopathy, whereas those who did not have painful shoulders returned to baseline immediately without thickening and without reduction in the subacromial space. So they concluded that tendon thickening may be an early pathologic response that may subsequently lead to tendon compression as a secondary phenomenon due to the larger tendon occupying a fixed subacromial space. And we stated in an earlier discussion that changes in the extracellular matrix and changes in the collagen fiber composition of tendon are early pathologic changes in tendon. Later pathologic changes in tendon involve changes in the tendon cells, such as disorganization of the tendon cells, such as morphologic reversion back to primitive progenitor stem cell types, and such as early cell death also known as apoptosis. So changes in the cells represent later changes, whereas changes in the extracellular matrix are early initial changes in the structure of the tendon. So they concluded that tendon thickening due to change in the extracellular matrix becoming more puffy, more aqueous, may be an early pathologic response, which then basically adds salt to the wound because it leads to tendon compression in that fixed subacromial space. And this phenomenon is worsened in those workers who are older due to progressive changes in the size and shape of the acromion process. So here are some of the risk factors for the development of shoulder tendinopathy in the industrial setting. So first and foremost, number one is repeated or sustained shoulder postures with more than 60 degrees of either shoulder flexion or shoulder abduction, which is the source of both tensile and compressive loading of that rotator cuff tendon. Now, this repeated or sustained shoulder posture is aggravated and worsened by adding a load to the end of the hand, such as when holding a tool overhead. And even as much as a 2-pound tool can significantly increase the tensile and compressive loading on that rotator cuff tendon. And the height of the hands in relation to the shoulder determines the shoulder workload. With the shoulder workload increasing, the higher the hands are in relation to the shoulder. So mechanical pressure on the tendon from the acromion, in other words, the direct compressive pressure on the tendon, is greatest between 60 and 180 degrees of arm elevation, either arm abduction or arm flexion. So let's take a look at what this looks like diagrammatically. So here we have an image of a worker in the California workers' compensation system who does repetitive work with his arm at approximately 115 degrees of shoulder abduction. And at this range of motion between 60 and 120 degrees of shoulder abduction or shoulder flexion, we see here that the rotator cuff tendon here is going to be subject to both tensile and compressive loading. So the tensile loading comes from the supraspinatus muscles contracting along their line of pull linearly here, comes also from the deltoid muscles contracting and pulling linearly along their line of pull. So we're going to see tensile loading here on the supraspinatus tendon. In addition to tensile loading, we're going to see compressive loading as this supraspinatus passes underneath the acromial process and as it passes underneath the coracoacromial ligament here as that arm goes into greater and greater degrees of flexion and greater degrees of shoulder abduction. Now imagine if there's any change in shape of the acromion process from type 1 towards a type 2 and certainly towards type 3, the available mechanical space underneath the acromion process is diminished. And further, if there's any hyperemia or swelling or increase in size or thickening of this supraspinatus tendon here, then of course that's going to create greater and greater mechanical impingement. And you've heard of this described in your clinical practice as impingement syndrome, and this is the source of it. So for purposes of this slide, I just want you to become impressed by the poor fate of the supraspinatus tendon being subject here to great tensile loads as a load is applied downward along the length of the arm bone here, and then also by the great compressive loads as this tendon is sheared underneath the acromion process here, and friction is created and abrasion is created under the acromion process here. Well, it's a very fine line between an adaptive loading on the tendon and a pathologic or degenerative loading on the tendon. But once the homeostasis in the tendon is disrupted and the tendon fails to return to baseline before repetitious activity is again initiated, this sets the stage for changes in both the extracellular matrix and also within the cell structure of the tendon, leading to degenerative tendinopathy that likely will not return to pre-injury condition, certainly if there are no modifications in the loading protocol. Now, in this same study, they found that work above the head, especially combined with upward exertion and far reach, requires the highest muscle demand. So upward exertion would involve something like putting in a light bulb, would involve something like painting a ceiling, would involve something like installing an overhead fan. This upward exertion against gravity and load, combined with far reach, requires the highest muscle demand and places the greatest amount of both compressive and tensile loads on the rotator cuff tendon. Now, interestingly, even with a shoulder flexion angle of only 15 degrees or greater, it's been found that adding pinch grip force greatly increases the risk also for the development of shoulder mechanical impingement and the development of degenerative tendinopathy. So there seems to be something about application of pinch grip strength which contributes to the high muscle demand of the supraspinatus muscle and the supraspinatus tendon. In a study of hairdressers, electricians, and 11 other occupations, it suggests that prolonged arm elevation greater than 60 degrees is an early work-related risk factor among women. So when considering some of these 11 other occupations, what are some of those other occupations that might come to your mind? Well, what about those people who drive for a living? When you think about the different types of drivers, from bus drivers to truck drivers to taxi drivers to Uber drivers to delivery drivers, it seems that drivers are at high risk for the development of shoulder tendinopathy. Most driving conditions result in moderate, meaning greater than 30%, to high, meaning greater than 50%, of activation of the supraspinatus and deltoid muscles, with most of the loading being in the eccentric muscle action, which many times has greater force development than even the concentric muscle action. So they concluded that this level of loading is up to 72% of the mean supraspinatus failure rate and likely could be exceeded even in normal driving conditions, especially for truck drivers that use those large steering wheels that require large circumferential movements of the shoulders. In fact, they found that truck drivers have more than 3 times the musculoskeletal disorder incident rate, or their rate is 3 times greater than the rate for all private sector workers. And again, it's because of this position, the sustained elevated shoulder flexion and sustained elevated shoulder abduction, that creates tensile and compressive loading on the supraspinatus tendon and also compromises the subacromial space. So let's take a quick look at the subacromial space and what's referred to as the acromiohumeral interval. So here we have 2 x-rays of the acromiohumeral interval, and one of the x-rays depicts a normal acromiohumeral interval and the second depicts a compromised acromiohumeral interval. So before we discuss the acromiohumeral interval, it's important to understand that the acromiohumeral interval here, this space below the acromion process and the head of the humerus, is maintained by the normal action of the rotator cuff. So remember, the function of the rotator cuff muscles is twofold. Number one, of course, is to rotate the head of the humerus, with the subscapularis being an internal rotator and the infraspinatus and teres minors both being external rotators. But also the function of the rotator cuff, especially the infraspinatus and teres minor muscles, is to depress the head of the humerus within the subacromial space, to maintain the subacromial space open and clear, so that the space can remain open and clear and allow for full range of motion of the head of the humerus within the subacromial space. So when the rotator cuff is painful, when it's dysfunctioning, when it's diseased, when there's tendinopathy of the rotator cuff tendons, we have failure to depress the head of the humerus in the subacromial space, and we see an obliteration of the subacromial space here. With obliteration of the subacromial space, the head of the humerus rides high in the subacromial space and causes impingement of the rotator cuff tendon along the inferior surface of the subacromial arch. And that's what's being depicted here in this diagram. You can see that this head of the humerus is riding high in the subacromial space, and there is contact here of the tendinous structures underneath the surface of the acromion process. So it's kind of a situation where, due to many factors, we talked about changes in shape of the acromion process, we talked about thickening of the rotator cuff with fatigue and loading. And also, once the rotator cuff becomes painful and once it becomes degenerative, it starts to fail in its function to be able to maintain an adequate acromio-humeral interval. Further compounding the mechanical impingement in the subacromial space. So it kind of becomes a self-fulfilling downward vortex of problems that drive the rotator cuff tendon badly into impingement and subsequently badly into a degenerative tendinopathy phase. So in recognizing these types of phenomenon and the difficulty in recovering to a pre-injury condition, many of these examinees are going to come into us having failed physical therapy, having failed conservative measures, and they're going to have ongoing painful sequela, and they're going to have limitations to activities of daily living as a result of shoulder pain and dysfunction. So let's talk now about some of the impairment options and alternatives that you have available to you in order to provide these examinees with an accurate permanent impairment rating. Now, the AMA guides provide for us 5 possible options that we can utilize in coming up with an impairment rating that's an accurate description of the examinee's current condition and an accurate description of the impact of their condition on their activities of daily living. So one of the impairment ratings that are described by the AMA guides involves shoulder arthroplasty. And the AMA guides refer specifically to resection of the distal clavicle. So resection of the distal clavicle is the only shoulder surgical procedure that's described in the AMA guides. And the AMA guides specifically provide for permanent impairment for this particular procedure. But you can also provide for permanent impairment for your examinee by analogy to any other surgical procedure. And I know many doctors that provide a permanent impairment rating by analogy to resection of distal clavicle when the examinee has had a surgical procedure on the shoulder, even if the surgical procedure on the shoulder does not involve resection of the distal clavicle. So we'll talk about some of those other surgical procedures that you can analogize to resection of the distal clavicle. Okay? Number 2 is the AMA guides provide for permanent impairment due to abnormal range of motion of the shoulder. And with abnormal range of motion of the shoulder, Some, generally not all, of the ranges of motion may be affected, such as flexion, extension, abduction, adduction, internal and external rotation. Similarly, the AMA guides provide for loss of strength, again, to all of the above ranges of motion. So you want to test the examinee in shoulder flexion. You want to test the examinee in resisted shoulder extension and abduction and adduction and internal and external rotation. And the AMA guides provide for a permanent impairment rating in those cases where there is a bona fide loss of strength due to shoulder tendinopathy. We know that tendons contribute to the stability of the shoulder joint. Normal tone in the tendons contribute to tension across the joint, which contributes to the stability of the head of the humerus in the glenoid fossa. It's not the only contributor to shoulder stability. We also have the glenohumeral ligaments and the shoulder capsule. But injury and damage to shoulder tendons can result in laxity of the shoulder and instability of the shoulder. And the AMA guides provide for permanent impairment due to shoulder instability. If that shoulder instability is related to weakness and loss of function of the rotator cuff, that would be an example of applying a shoulder instability impairment to a tendinopathy condition. Also, the AMA guides provide for permanent impairment due to neurologic effect on the shoulder, such as a result of brachial plexopathy, or perhaps an injury to the peripheral axillary nerve that causes a loss of function of the muscles in and around the shoulder and contribute to a drooping shoulder. This is not something that we're going to see very commonly. Most commonly, our permanent impairment ratings for shoulder tendinopathy conditions are going to involve some combination of impairment due to arthroplasty, some impairment due to decreased range of motion, some impairment due to decreased strength, and some impairment due to shoulder instability. Now, the AMA guides tell us that we cannot combine impairments due to decreased strength with impairments due to shoulder instability, but we can combine impairments due to decreased range of motion and shoulder instability. We can combine impairments due to arthroplasty, decreased range of motion, and decreased strength. And we can combine impairments due to decreased range of motion, decreased strength, and shoulder instability. And therefore, range of motion can be universally combined with the other impairments and will most likely be involved in all of the impairment ratings for shoulder tendinopathy conditions. Okay, so let's talk first of all about some of these different surgical procedures that can be analogized to resection of distal clavicle. Now, as you review the medical records of your examinee, you're going to come across many descriptions of shoulder surgical procedures in addition to, or sometimes in place of, resection of the distal clavicle. So some of the descriptions that you might read in the medical records might involve arthroscopic Mumford procedure, for example. Or you may see an examinee who has undergone a biceps tenodesis procedure. Or in the case of a fracture, the examinee may undergo an open reduction internal fixation procedure. Other shoulder surgery procedures involve subacromial decompression, resection of the coracoacromial ligament, arthroscopic debridement, and a glenoid labrum repair. And this is not a complete list. It's just a list of some of the common procedures that examinees undergo. Now, many doctors provide for permanent impairment for these surgical procedures by analogy to resection of the distal clavicle. Now, this raises an interesting question, and it's a great topic for discussion. And that is, why do the AMA guides provide for permanent impairment due to resection of the distal clavicle? Resection of the distal clavicle is the only surgical procedure described for the shoulder in the AMA guides. And the AMA guides provide for 10% upper extremity impairment for this specific procedure. So why do you think that is? What is the impairment that results when the distal clavicle has been resected? And why would some of these other shoulder surgical procedures also qualify for permanent impairment by analogy to resection of the distal clavicle? Well, I've gone on record as stating in the past that these surgical procedures here do not analogize to resection of the distal clavicle because the impairment associated with resection of the distal clavicle is unique. The reason that the AMA guides provide for permanent impairment due to resection of the distal clavicle is that resection of the distal clavicle destabilizes the acromioclavicular joint and destabilizes the clavicle itself. And when the clavicle is destabilized, we subsequently have a loss of support for the neurovascular structures that pass on top of and below the clavicle, such as the brachial plexus and such as the subclavian vessels. So with a resection of the distal clavicle, it leads to impairment associated with compression of the neurovascular structures. Well, none of these other surgical procedures result in that specific impairment because with these other surgical procedures, the distal clavicle remains intact. However, many doctors consider the impairment due to resection of the distal clavicle simply an impairment that's related to having the shoulder joint itself opened surgically and manipulated surgically, and the fact that once an articulation is manipulated surgically, that it's never the same thereafter. So many doctors believe and many doctors provide for permanent impairment for any surgical procedure in the shoulder by analogy to resection of the distal clavicle. So many doctors use these surgical procedures to provide for permanent impairment of the shoulder by analogy to arthroplasty. And you can feel free to use these to provide for permanent impairment for any or all of these shoulder surgical procedures. So let's take a look at a couple of these surgical procedures. So here we have an x-ray that depicts a resection of the distal clavicle here. You can see that approximately 1 centimeter of distal clavicle has been removed, thereby destabilizing the acromioclavicular joint and destabilizing the distal clavicle here, creating a loss of support for neurovascular structures that pass between the clavicle here and the first rib here. So that's the reason that the AMA guides provide for permanent impairment due to resection of the distal clavicle, and is why no other shoulder surgical procedure is described in the AMA guides. Well, that fact notwithstanding, many doctors do provide for permanent impairment for other shoulder surgical procedures, such as, for example, bicep tenodesis. Many examinees will undergo a bicep tenodesis where a diseased tendinopathy, biceps tendon here, and its attachment at the sensitive and delicate glenoid labrum here is simply removed, and the bicep tendon is adhered in the intertubercular groove here through some surgical hardware, which places the tendon, the origin of the tendon, at a different location. So because this is an arthroscopic procedure similar to resection of the distal clavicle being an arthroscopic procedure, many doctors consider a biceps tenodesis to be analogous, at least in terms of its impairment rating, to a resection of the distal clavicle. Sometimes in your medical records you'll hear the surgical procedure described as an arthroscopic acromioplasty, wherein the acromion process here is shaved and debrided to remove bone spurs, to remove built-up material along the undersurface of the acromion process, In the case of a hooked type 3 acromion process, many times that hook is shaved off and removed in order to reestablish the subacromial space and to allow freedom for translation of the supraspinatus tendon through the subacromial space. So that's arthroscopic acromioplasty. And many doctors provide for permanent impairment due to this surgical procedure by analogy to resection of the distal clavicle. Also, sometimes in order to decompress the supraspinatus tendon, orthopedic surgeons will do a resection of the coracoacromial ligament. Now, the coracoacromial ligament is fascinating. As you know, ligaments connect bones to bones, and we frequently find ligaments at joints where a ligament attaches to a bone on one side of the joint and attaches to another bone on the other side of the joint. Well, the coracoacromial ligament does connect bone to bone, but it connects the coracoid process here with the acromion process here, which are processes on the same bone. So the coracoacromial process is not involved with stabilizing and articulation, but it simply provides a connection, a connective tissue connection between two processes on the same bone. And so many orthopedic surgeons feel that this ligament can be sacrificed with no loss of stability of the shoulder complex itself, but removing the coracoacromial ligament here removes the roof or the ceiling of the subacromial space and can reduce the compressive loading of the tendon as the tendon passes underneath this coracoacromial ligament during shoulder flexion and shoulder abduction. And if your examinee has a resection of the coracoacromial ligament as part of their shoulder repair, you can provide, by analogy, you can provide for permanent impairment for this surgical procedure by analogy to resection of the distal clavicle. So far we talked about permanent impairment for shoulder tendinopathy due to either the exact surgical procedure of resection of the distal clavicle or any other similar surgical procedure on the shoulder. We talked about combining impairments due to loss of range of motion, combining impairments due to loss of strength of the shoulder, and by combining impairments due to any loss of stability of the shoulder. So those are the impairment ratings that we have available to us under the strict application of the AMA guides. Now, every once in a while, you may have an examinee who is not accurately described, or I should say whose impairment is not accurately or completely described under the strict application of the AMA guides, and you may elect for an alternative impairment rating under Alvarez and Guzman to more accurately describe the permanent impairment. So one of the options that you have available to you is to provide for permanent impairment by analogy to abdominal herniation in Chapter 6. Now, this is particularly relevant for those examinees who have a loss of lifting capacity as a result of either a shoulder surgical procedure or as a result of a degenerative tendinopathy of the shoulder, which simply leads them with a painful and weak shoulder and a loss of activities of daily living, specifically those that involve lifting. So in an examinee who is involved with lifting on a regular basis in his daily and in his work life, who suffers a loss of lifting capacity, that loss of lifting capacity may not be adequately captured in, in the permanent impairments under the strict application of the AMA guides, and you may elect that in order to most accurately describe the impact of this shoulder condition on the examinee's daily living and work activities, that you need to invoke or employ an analogy to Chapter 6 hernia. So most commonly, these examinees will fall into the Class 2 impairment rating, and this is due to frequent shoulder discomfort that precludes heavy lifting, but not hampering some activities of daily living. So if you have an examinee who has frequent discomfort in the shoulder, and that frequent discomfort in the shoulder precludes them from doing heavy lifting, this is an impairment that may apply to them. And this is particularly relevant in those cases where you have written work restrictions from the primary treating physician precluding the examinee from engaging in heavy lifting. So, for example, if the most recent medical record that you have from the primary treating physician indicates that the examinee is lifting limited to, say, no lifting greater than 20 pounds above shoulder level, in an examinee who prior to the development of shoulder tendinopathy was unlimited and unrestricted in shoulder lifting activities, this is an impairment rating that could appropriately be applied to that particular examinee. And then when you employ this impairment rating, this alternative impairment rating, you have the option of providing a range of permanent impairment ratings between 10 and 19% impairment of the whole person. Now, this is a substantial permanent impairment rating. It provides for anywhere between 10 and 19% whole person impairment rating. So, which examinees qualify for the lower value and which examinees qualify for the higher value is largely subject to your clinical decision making, but the examinee who's greatly restricted and even precluded from lifting activities would qualify for the higher value within the range, whereas an examinee who's only mildly or moderately restricted in lifting activities would qualify for a lower value within the range. And I'm thinking of a recent examinee that I had who was a dock worker in receiving at Walmart, and he was involved in constant daily lifting of unloading boxes and packages and dealing with pallets out there on the receiving dock at the Walmart warehouse. Well, as a result of a shoulder tendon injury, in other words, an injury to the rotator cuff, his primary treating physician restricted him to no lifting greater than 2 pounds. 2 pounds, if you can imagine that. And this was a large and a young individual. He was over 6 foot. He was over 200 pounds. He was otherwise muscular and athletic. And prior to the industrial injury, he was unlimited and unrestricted in his lifting capacity. So basically, by being restricted to no lifting greater than 2 pounds, he had nearly a 100% loss of his pre-injury capacity for lifting. So I opined that this qualified for the higher value within the range. And in addition to permanent impairments related to loss of range of motion and shoulder instability, I was able to provide for an additional 19% whole person impairment in most accurately describing his final right shoulder impairment.
So doctors, I hope this helps you. Of all the tendinopathy conditions that you're going to see in your qualified medical evaluator practice, shoulder tendinopathies are by and far going to represent the largest population of examinees of all the tendinopathy cases. Due to the weak and highly mobile nature of the glenohumeral joint, this area of the body is subject to the development of degenerative tendinopathy. So you're going to be seeing these cases. So in these cases that involve shoulder tendinopathy, you can provide for permanent impairment for these cases due to decreased range of motion, loss of strength in any and all of the 6 directions of testing for resisted manual muscle testing. You can provide for permanent impairment due to loss of stability of the shoulder. And then in those cases that involve a shoulder surgical procedure, right off the bat, the AMA guides provide for 10% upper extremity impairment for the specific surgical procedure of resection of the distal clavicle. But if your examinee has undergone a surgical procedure different from resection of the distal clavicle, you can provide for the same permanent impairment rating, which is 10% upper extremity, by analogy to resection of the distal clavicle. So any surgical procedure of the shoulder automatically qualifies for 10% upper extremity impairment, in addition to the other impairments associated with decreased range of motion, decreased strength, and/or shoulder instability. And then under Alvarez and Guzman, you have the option of providing for permanent impairment by analogy to abdominal hernia in those cases where the examinee has a loss of capacity for pre-injury lifting, or I should say has a loss of pre-injury lifting capacity. Yeah, let's say it that way. And you can determine this loss of pre-injury capacity for lifting by review of the medical records. If the medical records provide for work restrictions of no lifting greater than X, no lifting greater than Y, no lifting greater than Z, you can make an assessment as to what percentage of pre-injury lifting capacity loss that represents, and you can provide for permanent impairment somewhere between 10 and 19% whole person by analogy to abdominal herniation in Chapter 6. So doctors, I hope this helps you. You're going to be seeing these cases in large volumes over the course of your career. So you can plan on being able to employ these impairments probably within your very next examinee if the statistics are true. So I want to thank you for taking the time to join me on today's video. I look forward to being with you on our very next video, wherein we're going to go into elbow tendinopathies. So for now, this is Dr. Perry Carpenter wishing you best of success in your career as a qualified medical evaluator.